all. Thanks so much for watching Making Healthcare Work for You, Different Perspectives and Empowering Solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta, and today we are welcomed by two really amazing guests, Dr. Tina Ann Kerr-Thompson, who is the Senior Vice President for the Primary Care Service Line and the Division Director of Family Medicine at Emory University School of Medicine, and the Executive Director of the Emory Healthcare Population Health Collaborative. And we are welcoming Dr. Dan Salinas, who is the Chief Medical Officer and Chief Quality Officer for Emory Healthcare Population Health Collaborative and Assistant Professor for the Department of Family and Preventive Medicine at Emory University School of Medicine. Thanks so much for being here.
Thank you for having us.
You're welcome.
We are so happy to talk to you today, and we have a couple of different things, but all revolving around, Tina Ann, as you called it in our pre-interview, the circle of care, which I really loved. It's such a unique perspective that you hear about. Here, let's have a 360, but you really saying the circle of care brings that focus really to light, and I loved that. So you were talking about the shift from fee-for-service to value-based care, and then how you're helping all of these people, the patients, the clinicians, make that transformation and really feel it. And then you also told us in our pre-interview that this has been a focus for about 10 years, but you've really put a lot of resources and focus in the last 18 months. So I would love to hear from one or both of you about what that transition's been like and why it's so important now.
In my experience as a primary care physician at Emory at Rockbridge and Stone Mountain, so from the personal experience, I'll start with that. When we see a patient at our offices, we hope that the decisions that we made as a shared unit are carried out. The prescriptions that are written or taken, the recommendations for diet and exercise are done. But we know that something happens often between that visit and the next time the patient sees us in 3 to 6 months or 12 months, or even longer than that. And so what the population health focus has been on is making sure that those decisions that we made, those orders that we provided to the patient actually get done. So now we have a focus on calling the patient in between the visit and saying, Ms. Smith, I see that you haven't been able to get your mammogram done. Is there anything that I can do to help to facilitate that? And so we do that with our care guides. We do that with our medical assistants. We do that with our nurse coordinators. We do that with our care gap closure experts is what we call them. And they are able to reach out to the patients and ensure that the care that we talk about is carried out. And we've done some of it with artificial intelligence as well, where we're reaching out to the patients to find out about the reasons that their blood pressures might not have been well controlled at their office visit. Maybe it's better controlled at home. And so that feeling of being able to care for our patients between visits is such a relief for physicians and other clinicians that the work is getting done, even though we only had 15 to 20 minutes on a good day to be able to take care of the patient. In between, something is happening to ensure that those decisions are actually carried out. And it feels better. And it just is a reassurance that our patients are cared for.
And if I could add also why I think circle of care is so important, with everything that Tina Ann described, if I could just pick one word, it would be accountability. And accountability is, so what Tina Ann described, this circle of health or circle of care, it's a team sport. And long ago, the patient's role was not as clearly defined, I would say. Things were given to the patient, things were done to the patient. Now if you look at it from accountability perspective, we all still do all of those things, but now the patient really has to be accountable as well to make sure that they're a part of the decision. You'll hear more and more talk about shared decision making. It's more critical now because it's so complicated, more critical now than ever. So having clear delineation of accountability for everyone on this team is what's needed to deliver this circle of care or circle of health that Tina Ann described.
That's awesome, Dan and Tina. And as actually, Dan, as you were saying that, the one word that was coming to me was a little bit different, but I probably related. And I was thinking just confidence when I was hearing Tina Ann speaking, particularly, it just felt like, wow, even though I've had just such a small amount of time with the patient, I now have the confidence, probably because of the accountability that Dan is describing, that what needs to happen is going to happen. So that just seems like really remarkable and probably the way in which care needs to be designed. It does seem like a lot of resources that need to be brought in and a lot of coordination that needs to happen. So can you tell us a little bit about how those resources are being brought in? How are they coordinated? Is that where Guidehealth comes in? I think some of those resources may be internal to Emory and some may be external as well in partnership. Maybe you can both describe that a little bit in terms of how those resources are being coordinated.
In our Pop Health Collaborative, the big focus is primarily on primary care because the primary care physician is the leader of this team that we mentioned. Now, there are specialists, they're very critical in the care of the patient. And back to accountability, Tina Ann and I are working with others to really be clear about what's the primary care doctor's accountability, what's the specialist accountability, the nurse on the team, and as I mentioned, the patient, et cetera. So it takes a lot of people to do all of that. So we have at the foot on the ground level, of course, there are medical assistants and nurses in offices and others that really work to help the operations of a practice really work extremely well. And so those who are delivering care are tasked with delivering evidence-based care. And if we do that, in general, things work well. But the trail of evidence that evidence-based care has been delivered is not always clear to the payers who are paying us not just to deliver care, but they're paying us to keep patients healthy in between. And so we have a team that surrounds us of what we call guides, health guides, or population health coordinators that really help take that evidence and turn it into a story and into bits of data and information that the payers receive and where we can demonstrate that these gaps in care have been closed. And then, of course, we have nurses, registered nurses that work both with our employed group and with our community primary care physicians to help those patients, help their patients make transitions from ER back to their offices, inpatient care back to their offices, identifying patients that are at risk for hospitalizations and reaching out to them to make sure that they're getting the care that they need.
Is that whenever you implemented the Guidehealth then, using those the guides, and then you mentioned AI before, is that where you guys partnered with Guidehealth?
That's right. So Guidehealth helps to put the data directly in front of the clinicians so that we understand which patients need to be outreach to more. And so stratifying our outreach so that we reach out to the patients who are sicker, who need more care, and reaching out to them in the ways that they need to be reached out to, as opposed to some of our patients who may be lower acuity, who have higher digital exposure. They're able to interact with us with AI, with text messages, with our electronic health record portals. We are able to leverage our resources in the most efficient way with the expertise of Guidehealth. And the other thing that we do is what we call standard work, right? So we are making sure that everyone on our team understands the goals and everyone is doing the same, and moving in the same direction, and that the medical assistants are all doing the same work medical assistants do, so that when we have staff turnover, when we have a new practice that is going to start as we grow, everyone knows their role in this entire circle of care.
I love that. And you told us in the pre-interview that whenever you looked back on this first year, that the results were really pretty amazing. And so does that help? And I guess this is a question for both of you. Being able to see the results that happened whenever you put in this approach into place for that first year. Dan, you told us that you really liked the quality improvement science and that you wanted to help people understand what population health management is. So having results like this, does that help you then better translate and say, yes, here's what this is and here's why this matters. And look, when we focus, here's how these things can play out, because it really is the full body approach to people. And you said it was the mental health plays such a big role in primary care. And Tina Ann, you said, you're the one seeing the patients, you care, you want to be part of them. So again, the question, does having results that you said were great for the first year help you put that into practice? You kind of reverse engineer it and say, yep, here it is. This is why it matters. Now let's go. This matters, because you've known all along that this was so important.
This is such a critical part of the discussion, Stephanie. With physicians, they need to understand the why they're being asked to do something. It's so important to them because they have so much to do, not only for every individual patient, but for their entire day. And so we spend a lot of time up front talking about the why, talking about what's the value proposition of delivering care in this way. Because for years, we've been delivering care, we get paid for it, we deliver care, we get paid for it. And now we're saying we need to keep doing that to a degree, but we also need to focus on delivering care that is so good and so focused on prevention that patients don't have to come in. So when you do that and you do it well, in today's world of reimbursement, the value-based care reimbursement, the payers reimburse us for doing that job really well also. And so with that, with those payments comes the ability to invest more in this infrastructure and then to do more for every single patient that walks in through the door. We have about 420,000 what we call attributed lives that are part of our contracts. But for Tina Ann's practice, our attributed lives make up about 40% of who she sees. So there are 60% others that she has seen that aren't part of these contracts. But because we're doing so well at this, they get the benefit of it. And that is truly population health management.
Exactly. And to Dan's point about ensuring that all of our patients get this high level of care, we are doing the standard work of outreaching to our patients at our clinics when they enter the hospital, when they discharge from the hospital, no matter which hospital they go to, whether they go to one of our Emory facilities or one of our neighboring hospitals, our nurses in our clinics are outreaching to each and every patient, regardless of risk. Now, our higher risk patients are getting additional outreach from our RN care coordinators who have additional expertise in care coordination and care management. And our every other patient is still getting the same outreach. And we're starting to see big results. And, we're clinicians, we're scientists, we went to school for a long time. We like to get good grades. We like our patients to get good care. And we like to see results. We're results driven. And so when we see that our patients' blood pressures are under better control, we see that our diabetes scores are doing well, those numbers are attached to humans. And that just feels good. That those things are happening. We're making a difference in our communities. So a lot of us live and work and play and go to church in our communities. And so these numbers really do mean something, that 80+% of our patients have diabetes scores that are under control. It feels right.
So Tina, and actually, as you were saying that, I'm smiling because I was just thinking of asking you to double click on that a little bit more. You mentioned a couple of scores that have improved blood pressure and diabetes. Are there other scores that you can preview for us that have also improved? And it seems like this is probably going back to, yeah, answering the why that Dan was talking about, in terms of once the outcomes are there, then it goes back to building the accountability and the confidence that the clinicians have in the system. So we'd love to hear more about what outcomes other than those two may have improved as well.
So one of the areas that we've improved in is transitions of care. And so getting 4 and 5 star ratings from some of our payers on our transitions of care has been a valiant effort from a lot of our folks. As you can imagine, in primary care spaces, if you've tried to get a primary care appointment in the next 7 to 14 days, sometimes it's challenging. But we have been able to open up spaces so that our patients are able to get in, so that access is not a barrier to being able to get in to see our patients between 7 to 14 days. The way we've done that is through standard work. We've done it through templates. We've made it easier for our clinicians to be able to do the work, make it easy for the LPN and the RN to be able to document the information from the patient. Ideally, we'll start to use AI to collect more information from the patient so that the nurse can just focus on the barriers. And then we've made it easy for the physician and the APPs to document and do the work as well, so that they can focus on the actual care of the patient. Because we know we don't love a documentation. We're also using AI to help us with doing some of the documentation as well. The other area that we've excelled in is the performance of the annual wellness visit. And while it's not an outcome measure yet, we know that annual wellness visits are associated with higher rates of prevention, and having those patients have higher rates of breast cancer screening and higher rates of colorectal cancer screening, higher rates of pneumonia vaccines. And so we know that if we improve our rates of completion for annual wellness visits, our patients will eventually get the better care. And so what we saw this year is that we went from being in the 30s for completion, 30% completion of annual wellness visits, to the 70s percent. And in some areas, in some of our vulnerable areas like LaGrange, we have seen upwards of 90% completion of annual wellness visits. How do they do it? We've made it easier with the template. We've said this is just part of what we do. It's now just the culture of the place. We all know that all the strategies in the world mean nothing if we don't change the culture to say, this is how we do it here. We do annual wellness visits here. So whether you come in for maybe not an acute febrile illness, but maybe if you come in for something like a chronic condition or something minor, we will do our annual wellness visits so that we can present that personalized prevention plan that is now, again, just easier to do within the electronic health record, so that the patients can get the care that they need, and the physicians and clinicians, nurse practitioners, the PAs, just feel that sense of accomplishment that, 90% of my patients have received this additional care that Medicare has reimbursed and is reimbursing well, because the CMS sees that this is a value add for patients. And so I know I'm talking a lot about how we feel, but in this job, it really does matter how the patients feel about coming in to see us, and their experience and the clinician experience is really vital to our performance.
If I could add one little capstone to everything Tina Ann just said, if we do everything right, like she described, which we're doing, we have a better accounting of all the conditions that the patient has, what's resolved or what's continued, and maybe there've been new conditions since the last time the patient was seen, and we're able to document that. The better we document, it's called coding, where you appropriately, ethically document everything that is going on with the patient, then the payers, in this case, let's look at, you'll just say Medicare. Medicare is able to then see better how sick our population is. And if we document that right, we get reimbursed at a higher level because the patients are sicker. And in doing so, that gives us even more reimbursement to do the things that we talked about earlier, which is to hire the staff we need, to buy the technology we need, to appropriately reimburse our physicians, and even give our physicians bonuses for care that they're providing. So you start to see how all of this just fits into that circle that Tina Ann described at the beginning.
It all also goes back to what you were saying before, Dan, about accountability. Everybody has a clear role now, including the patients, Tina Ann, like you were talking about. So, what is that like? How are you able to make that shift? Because these are challenging times for all kinds of reasons right now. And so, being able to have these results that you've seen is remarkable. People completing those visits. I mean, it really shows that you are capable of being a trusted person in their life, somebody that they feel comfortable talking to, which is going to lead to these continued results. And for them following through, which is going to be better health. And again, everybody's going to feel like they're accomplishing goals, reimbursements are going to be higher, all the things are happening. So, how are you doing that? How are you really being able to build that trust in these ways and so concretely say, okay, we're a team and you're here and I'm here? It's almost like a football team that's winning, unlike the Steelers. I have to add that. So anyway, but everybody has their role that they have to do. And so how do you do that? Because these are challenging times and you are doing this at such a tremendously high level to get results like that is unbelievable.
I'll answer that with the other football analogy. My money and my son go to the University of Miami. And so we have been winning in that area. So at least some football teams are winning. Uh, we have a program called the Patient Family Advisors, and we depend on them to tell us how well we're doing. One of the things that they have said is, some of them have said is that we are getting calls from you. Emory is reaching out to us. Now, we're hampered by spam because the patients are bombarded by back braces and all kinds of other things, and loans and all of these things that are spam calls. And so we do have to come up with ways to outreach to them. Oftentimes we use my chart. Sometimes we do a text and say, we are going to call you. But when we start delivering on this high touch in between visit care, and we start to show that we care not just when they land with us, we are able to say, when you have a problem, you can reach back out to us. You can send a message. Our RN advisors will triage you. They will ask a question. They will answer your question, and they will perform a standard triage so that we can get you to the care that you need. Our emergency department is now providing care on demand virtually during the week. Our primary care physicians and APPs are providing care virtually on the weekends. So we've improved our access to say, we promise you that we will deliver, we will get you seen by someone. Could be virtual, could be a phone call, could be in person, may not be your specific doctor. It may be the location down the road, but we are delivering on the fact that we will see you and meet your needs when you have them. And then, when they get results too, it also feels right. When they come in to see us and we ask them questions that leads to some sort of a diagnosis that they didn't even think that they had, and then we're able to connect them to care very seamlessly because we're all connected within our electronic health record. And so we can all wrap around the patient with our communication. They're starting to feel the difference. And this is a different way to deliver care. And we're telling them about the difference, and they are telling us about the difference. And so once again, it does begin to perpetuate that we are starting to get these early wins, and they're starting to feel them.
It's amazing because I was going to ask that question, Tina Ann, and you preempted that, which is that the circle of care is working for you and it's working for the patient. So it's not simply, in inside out or outside in perspective. It just really seems to be something that's coming together all around for the entire community, which is incredible. One question I do have, which is a good thing because I don't want to make it feel like this is a negative question, but there's often a lot of barriers that still come up in this process, and patients that you may not be able to get to, even if you're able to get from 30% to 70% of the patients, there's still some patients you may not be able to reach. The other barrier that I think you already talked about is making the model work for not only the patients that are in your system, but also the entire population, which it sounds like you've been able to handle. But I'd love to get any of your perspectives on any barriers that you still see that are emerging, that you now have set in your sights for 2026. Anything like that coming up for you?
One of the biggest barriers, and we're fixing this, is access to mental health care. Mental health issues, especially anxiety and depression, are occur comorbidly or together with so many different conditions, and it's hard to know what came first, the depression or the diabetes, or the diabetes caused the depression. Either way, the gold standard for mental health care in our world would be to have an integrated mental health professional present in every practice. That is doable, but is quite expensive to do. So the second thing is to have a network of mental health providers that we can refer patients to early when we determine that they may have an issue, a mental health issue that requires the assistance of a professional. And that professional can be a frontline therapist, LCSW, licensed psychological counselor, etc. It doesn't have to be the psychiatrist, but the key is to get them there. So we are building, in addition to our integrated mental health model that we have in 5 of our practices, we're building an expanded network through our clinically integrated network where physicians can refer and have quick access to mental health providers. That's part 1. Part 2 is the patient needs to go, and we have to help the patient get there. And then part 3, which is just as important as part 1 and 2, is that when the patient is seen, we need communication back from the mental health provider to let us know what is going on, to let the primary care doctor know what is going on. That bidirectional communication heretofore has not been the strongest of the communications, because there's so much myth embroiled in mental health care and who can say what to whom. But if we do this right, we can get the patient to the right place, make sure that they're seen, and the primary care doctor becomes a partner with that community mental health provider in driving that care. So that barrier in our network is going away little by little. And the patients will get great results as a result of that.
We still have barriers of just financial resources, especially in certain areas of our population. Um, and those remain challenges, and we continue to need to increase our social workers so that we can find resources for them. The other barrier that we sometimes fight is misinformation regarding preventive care, regarding immunizations. And so, really trying to get our folks to be able to understand, and again, go back to that shared decision making, understand the risks and benefits of all of the interventions that we're trying to make in their visits. And then finally, I would say that there are not enough primary care providers. There are not enough physicians, not enough APPs, and we are going to need to continue to figure out how to provide the support for the patient with a finite amount of clinicians that are being trained and coming out into the workforce. And so that is why we have really doubled down on this concept of this circle, so that our physicians, our APPs, are able to provide care. We'd love to have very tiny panels and be able to know every single one of our patients and see them whenever they need to be seen. But the fact is that we do have a shortage, and that shortage will make it necessary for us to be creative and innovative as we try to reach as many patients as we can.
You never know. You may inspire people through this accountability and everybody feeling like they have a role. They may end up saying, you know what, I loved this. And teenagers may end up going to medical school and joining your primary care team.
It's incredible. What a conversation. I mean, I feel just that you both have taken such a careful, thoughtful, deliberate, even just through this, interviews, just, been able to really help us understand, help our viewers understand how you've carefully designed this into a really well-structured system that has a role for everybody. I really love it. It's becoming clearer and clearer to me why it's working. And I really, going back to the circle, I love that circle concept because you even have a role for the AI in the circle, and maybe seeing an expanding role of that as you're talking about the shortages. But one question maybe that I have for you coming off of that maybe we didn't talk about as much during the rest of this interview is what's the role of family and friends in being part of that circle? Are you able to activate them as well and get more of the community around the patient involved and in their care and support?
Absolutely. I'll start with the counter of that, and that is that I'm engaged in some research about loneliness and how
Mhm.
the loneliness affects outcomes. And so, with that, really starting to focus on the support around the patient. And so, some of the questions that we ask during our annual wellness visits is around loneliness and who is your support, and really starting to uh, leverage some of the data that we're getting from those annual wellness visits to figure out how we might intervene to ensure that our patients do have um, this care team at home. So really great question. It is top of mind for a lot of us now, as our patients start to live longer and outlive some of their partners.
Awesome.
It's
Thank you.
it's also very practical and pragmatic as part of this visit to also talk about advanced directives and power of attorney and all of those things that starts to ask who are those people that are accountable to do joint decision making with you if this happened or that happened. So that becomes very important. We learn more about this by focusing on social drivers of health and then actually having patients fill out these forms. These forms I know are there for another reason, but they also start a conversation that gets to per what you just said. Who are those people that will help you if you become incapacitated in some way?
Mhm. Amazing. Amazing to think of the breadth of resources and your thinking, your scope. I mean, you're not just thinking, hey, we're going to solve a few problems and get high scores. It's really incredible to think about how you're trying to bring the whole, all the resources, the health system resources, community resources, and external resources together. So thank you for sharing that.
I love that. And I love that you've built a system that allows everybody to think about the people who aren't in your office at that moment and really care for them at all times. That's something that I don't think most patients get the opportunity to feel, and it's something special that you're doing. So, and it's clear that you're both excited about the way that you're heading. So, thank you both so much for being here and for having this conversation with us. It's really amazing. You shared so many great insights.
You're
Thank
welcome.
you.
Such
Thank you.
pleasure. Thank you. I was only going to add, if this makes the cut, I can only imagine what more outcomes you're going to have very shortly. So hopefully we can have a second round of this maybe in 6 months or whenever you feel like you're ready and just continue talking about how you're continuing to address the barriers and meet the needs of the community.
Absolutely. Thank you.
Thank you. And thank you all for watching. We'll talk to you soon. Bye bye.